Greetings on expert perspectives from the second day of the conference on hematologic malignancies called Lymphoma and Myeloma 2015. I am Dr. Morton Coleman, Director of Center for Lymphoma and Myeloma at Weill Medical College of Cornell University and the New York Presbyterian Hospital. I am the chairman of the conference, and I'm happy to have with me here today Dr. Richard Furman, who led today's session. Dr. Furman is a professor of medicine at Weill Cornell Medical College and is in charge of our chronic leukemia program. Dr. Furman, greetings.
Thank you.
Tell us, what did you find as the most exciting revelation that we had today at our conference? We had a number of exciting papers. Which one did you find the most poignant in a sense?
Well, I think actually we had several talks today on really what's really going to become the most important area for us to focus on in the coming years. So right now we have excellent therapies that are very effective and very well tolerated in the form of the B-cell receptor antagonists. But I think there's a need, and I think we're starting to make inroads into identifying those people who are at risk of actually failing on BCR antagonists after a period of time, either due to the development of resistance, namely a single base pair mutation in a particular gene, or to the development of a Richter's transformation, which is not controlled with the BCR antagonists. And I think sort of identifying these patients early on, even at diagnosis or when they start on therapy, would allow us to sort of plan sort of alternate steps that might be able to be possible to consolidate them, or once in their remissions to even take those few patients who really are predicted to do poorly to an allogeneic transplant, with the idea of being able to sort of build on the response that they've gotten with the BCR antagonist before their disease relapses.
In this era of signaling inhibitors, do you think there still remains a role for chemotherapy in chronic lymphatic leukemia?
I do not. I think that the chemotherapies that we have are incredibly effective, but they're not going to be able to help extend our patients' lives at this point in time. The associated toxicities and the development of resistance really seem to be, we're at the point there where we can't make them any better than they already are. What I really like to acknowledge, and what I really think is an important treatment strategy that needs to be abided by, is that the use of chemotherapy does induce genetic damage and genetic changes that really allow an instability to develop in the genome that makes it possible for these patients to develop resistance to the BCR antagonists. So in essence, the strategy of holding the BCR antagonist until the second line of therapy and using something like fludarabine, cyclophosphamide, and rituximab up front really sort of defeats the whole purpose, because the DNA damage resulting from FCR is sort of the one issue that might enable patients to run into trouble on a BCR antagonist. When you look at the 1102 data from the Pharmacyclics phase 2 study of ibrutinib, we actually see that all the patients who didn't have a 17p deletion have remained in continuous response on ibrutinib.
What about those 17p patients who had never received prior therapy? How have they done with the new signaling inhibitors?
So we really have very few of those patients. The one experience that I can comment on right now, because it's been published, is the one patient who had a 17p deletion on the 1102 study, who actually developed a Richter's at about 8 months. And of course, the question is whether or not the Richter's had pre-existed going on trial, and that was just inevitable. But the most extensive experience comes out of the National Cancer Institute, looking at a group of patients who are 17p deleted. And by and large, the results are very good for the vast majority of patients. There is always going to be about a 20 to 25% group of patients who will progress at about 2 to 3 years.
Well, we have two signaling inhibitors on the market right now, and they have performed very admirably. There are some toxicities associated with them. However, very few patients truly achieve a complete remission, even though you can keep them on the drug for a long time and the response rates increase with the duration of therapy. But it doesn't look like these signaling inhibitors will provide us with an avenue to cure it. What do you think about a sequence of one of the signaling inhibitors to maximum response, followed by FC or FC, more appropriately FCR or FR, if the case, as the case may be, or even BR? Do you think there's a role there for chemotherapy in trying to achieve the potential for cure?
Not at all, actually. So I think it's unfair to say that we're not seeing a lot of CRs with these new agents. When you look at the data from the early patients, there's a continuous rate of conversion from PR with lymphocytosis to PR to CR. And we have patients who are achieving CRs at year 2 to 3. And while it makes it hard to do clinical trials because we never know when the best response is going to be, unlike FCR, where a patient's going to have achieved their maximal response, 2 months after the completion of chemotherapy, people on BCR antagonists will continue to improve their response as long as they're on it. And I think that, everyone who's still on one can continue and improve their response. And that's really the key component of them. So I like to think of BCR antagonists as potentially being like medications for hypertension. You just take a pill a day and it keeps everything under control. And even if it's for the next 25 years, things are still going to be, quite good in that regard.
Yeah, but these signaling inhibitors, however, are not without their toxicities, and some people may balk at staying on it continuously. I agree with you. You have to view it as hypertension. But we have about 4 years worth of experience now with the signaling inhibitors. What is the CR rate running generally at 4 years? Would you have any idea?
So the patients who are on from the original studies were really a mix of patients. The best group of patients are the phase 2 patients from the ibrutinib 1102 study, which is running probably about 10 to 15% CRs right now, with data published at 30 months.
At 30 months.
So the data are continuing to evolve, and that number is going to continue to evolve. But it's really, the importance is progression-free survival. And even if these patients never achieve a CR, as long as they're responding and they're asymptomatic and they're not progressing, we've really done our job.
Well, the holy grail is to ultimately achieve a cure, and at least from this prism at where we are right now, I'm not sure that the signaling inhibitors will in fact cure the patient. One has no problem with keeping a patient on a medicine indefinitely and have them live out their normal lifespan. But I think still most of us would like to one day achieve a cure in chronic lymphatic leukemia.
I do think, two issues in that regard. One is that the patients who tend to have problems with toxicities and the ones who wouldn't be able to stay on a medication long term tend to declare themselves very early on. So when you look at the data from groups that have looked at reasons for discontinuation of therapy, the vast majority of people who discontinue therapy due to adverse events are doing it within the first 6 months. And so patients who are on it beyond 6 months, the data suggests that they're going to be able to stay on the drug very long term without toxicity.
As reported at the meeting, the BCL2 inhibitors also offer a great deal of promise, and hopefully one will be on the market very shortly. And of course, the BCL2 inhibitor story is very exciting. Where do you think that's going to fit in with our signaling inhibitors?
So I think that really is the answer to the question you asked me, just a minute ago, which is that the one side effect we see with the BCL2 inhibitors, namely ABT199, is tumor lysis syndrome. And there have been 2 deaths due to tumor lysis on the drug. I think that anything that could safely debulk the patients and reduce the tumor burden and lessen the likelihood of tumor lysis syndrome really would make ABT199 a very usable and very safe therapy. So all of a sudden now, if we were to take a patient who had been on ibrutinib for a year and has had a marked reduction in their tumor burden, their lymphocyte count now is 20,000 instead of 200,000, and the lymphadenopathy is completely resolved. Giving them ABT199 would sort of sop up the residual disease that they have, and by no means would it be minimal residual disease, but there would still be frank residual disease, but certainly it will be taken care of. very effectively and very safely because the amount of disease that's present is significantly lower and what would sort of qualify as a safe range.
So clearly you prefer ABT-199 to chemotherapy as the 1-2 punch. What about using the two drugs together, ABT-199 and ibrutinib or adalimumab? Are you worried about overlapping toxicities or augmented toxicities? How would you like to employ the two drugs if it were up to you at this point?
I really think that the patients need to have a period of time on the ibrutinib or adalimumab first in order to debulk their disease. I believe, quite frankly, that the lymphocytosis induced by the B-cell receptor antagonists will increase the sensitivity of the CLL cells to the ABT-199. So using ABT-199 concurrently up front with one of the B-cell receptor antagonists would likely lead to increased tumor lysis risk.
What I was referring to was using the signaling inhibitor first, maybe for 6 months, and then using the combo at that point so you don't have to worry about rapid tumor lysis. Or do you think it would be better just to give one drug and then the other?
No, I would definitely
prefer?
continue the B-cell receptor antagonist because I do believe, keeping the cells out of those protective niches really is what makes them sensitive or increases their sensitivity to ABT-199. And so by forcing the cells out of the lymph nodes and into the blood, even when it's just a low cell count, really could hopefully achieve extremely deep remissions. One of the things that I think we need to remember when we talk about responses with B-cell receptor antagonists is that MRD has a very different meaning. So when we look at the data generated by the German CLL study group, namely with CLL 4 and 8, and MRD and its predictability of long-term outcome, it really correlates very nicely. And the patients who achieve a number of CLL cells less than 10 to the minus fourth really have a very good disease-free survival. Now the idea though is that if you were to take a patient who's MRD negative after FCR chemotherapy, and the study was designed to really look 2 months after the completion of FCR chemotherapy, and give them a BCR antagonist, you would likely be able to push those few cells that we know must be there because patients do relapse into the blood and make them MRD positive, whereas they might have been MRD negative before. And I think that that's a good thing. All of a sudden now we're pushing the cells out of their protective niches and enabling them to die, even if it's by attrition. And so in essence, the MRD bar becomes a tougher bar to achieve, but when we do achieve it, and I do believe we will, it will be with much better results.
We heard 2 outstanding lectures on clonal evolution, if you would. How does our understanding of clonal evolution help us in terms of achieving the ultimate goal of curing CLL patients, or certainly in giving them therapy? How would you use what we now know about clonal evolution and the influence of the environment on which clone will evolve? How would you use that, or do you think it's still in its infancy before we can employ it in the clinic?
Well, I think the biggest applicability of clonal evolution, as we're hearing it today, really relates to people who are getting chemotherapy. And when there are certain mutations that chemotherapy can't override, namely BRCA3 or SF3B1 or Notch1 mutations, you end up selecting for much more resistant clones. And with the chemotherapy and the clonal evolution that develops, these initial clones that were small in number will acquire not only increased numbers because of repopulating the CLL after therapy, but they will also pick up secondary hits that will make them more difficult to treat. So in the era of chemotherapy, the clonal evolution plays a very important role. I think in the patients on BCR antagonists, it becomes less of an issue because we all of a sudden have a therapy that is equally effective against all the clones. And in essence, it sort of enables us to avoid selecting for that bad clone. Now, one of the important aspects of this clonal selection that we will need to take a close look at is sort of identifying those abnormalities or those mutations that predict for patients who are going to not do well on BCR antagonists. And the most common one would be developing a Richter's transformation. So for something like Notch1 or immunoglobulin gene VH4-39, excuse me, knowing that your patient has those would give you an idea to sort of, when you see that clone beginning to emerge, that you can then actually use that information clinically and change therapy to something that might be much more capable to consolidate what's a more aggressive disease.
What they call clonal evolution, I think, is a euphemism for clonal selection, actually Darwinian clonal selection. When you give chemotherapy, do you think you induce other changes other than just selecting out clones? In other words, because of genetic instability, do you think that chemotherapy may induce new changes that weren't present originally when the patient was diagnosed?
Absolutely. I do believe that chemotherapy not only selects for the more resistant cells, but it also creates the DNA damage necessary to allow mutations and other mistakes to happen. We've done some studies looking in patients who developed single base pair mutations that made them resistant to ibrutinib. And at extremely high sensitivity, we've been unable to find that clone in pretreatment samples, suggesting that it evolved on therapy, even without the DNA damaging agent. But I think that we never can be certain, just because the size of the number of CLL cells present in these patients really would preclude us from ever getting down to a sensitivity that we'd be comfortable with. But with chemotherapy, even at our current levels of relatively insensitive methods, we do see, and when you look at the kinetics, it supports it, that these clones are sort of emerging very quickly after treatment.
One of the other topics which has come up both in our first day session of myeloma and as well as our second day session in CLL was Karti therapy. Would you tell us where you see Karti therapy going and tell us a little bit about it? And how does Karti therapy apply specifically to chronic lymphatic leukemia in terms of the antigen target and the such?
So I think Karti therapy is a very powerful tool that will one day really change quite a bit of how we're able to treat our patients. I think in CLL, some of the big obstacles that are going to need to be overcome before CAR T cells really enter mainstream is the risk of sort of cytokine release syndrome and toxicities associated with the cells after they're infused. And we're doing a great job in learning how to control that with IL-6 directed inhibitors. But I think the second thing is that we need to figure out a way to turn off the CAR T cell therapy. So we're getting better at enabling the CAR T cells to persist. And the best evidence now that's available really shows that persistence of the CAR T cells is the most important indicator of overall outcome. So we have patients whose CAR T cells persist and they do well, but then they're stuck without any B cells for the rest of their lives. And the question is how long is that going to be tolerable for? Now, the patients who lose their CAR T cells actually are usually losing them and then relapsing. So the idea would be to sort of, at a time of our own choosing, be able to turn off the CAR T cells, namely through a suicide gene or something like that. So the third generation CAR T cells, so the first generation really just had the chimeric antigen receptor with a transmembrane protein to anchor it. The second generation had the chimeric antigen receptor with either a 4-1BB or a CD28 portion anchoring it through the membrane and signaling, plus the CD3 zeta chain, sort of has enabled the cells to really persist and grow and thrive in the patients that are successful. The third generation CARTs, which haven't yet entered the clinic but will hopefully soon, actually use CD28, OX40, or 4-1BB in addition to this CD3 zeta chain. So there they use 3 co-stimulatory molecules and would likely enable us to sort of guarantee across the board much better persistence of the CAR T cells and actually hopefully enable the effectiveness to be much greater than the 40 to 60% response rate that we currently see.
So we're getting very expert at clonal expansion of the T cell. The question now is, how long do you need those T cells around before you get rid of them. We just simply don't know. Presumably, right now, the longer the better in terms of response rate. Of course,
Good
if
news
it's directed,
is certainly once you get rid of them, you can always put them back in.
right. Well, it would be nice to have an antigen that is not expressed on all B cells, and I believe Dr. Kipps may have such an antigen. Would you care to tell us about the antigen that he finds on CLL cells as a target for CAR-T?
So Dr. Kipps has really published widely on the Roar1 antigen. And the Roar1 antigen is really an embryonic antigen that is only present postpartum on the hematogones and CLL cells. And its actual expression on CLL does seem to play a role in enabling CLL cell survival. So the good news is that even if the CLL cells were to drop it, they probably would lose the selective advantage that it provides them. And so it's one of these ideal antigen targets that is part of the disease, and so it's unlikely for the disease to exist without it, and is not really present on any other cells in the body.
My understanding is it may be present on islet cells, but I don't know of any reports of diabetes. Do you?
No.
Now, one last question, which I think is of great clinical relevance to our audience, is how to handle P53 if it's diagnosed at the initial time when the patient walks into your office who has never been treated, and you find P53. Do you think you could make a case for early treatment, or would you still continue to wait until the patient fulfills the right classification? Is there any merit, do you think, in early treatment, or should we just continue to treat them just like any other patient and wait for them to either become thrombocytopenic or anemic, et cetera?
So we really don't have data, but I do believe, based upon what we know, that when a patient who presents with a 17p deletion, which that and complex karyotypes really seem to be the hallmark of the genomic instability that leads to a great deal of problems in terms of resistance to the BCR antagonists or to Richters, actually would prompt me to treat those patients sooner.
How would you treat them?
Well, I would treat them with something that's going to be effective against the 17p deleted CLL, namely a B-cell receptor antagonist. And what I think is interesting is there are certain groups of patients, so the 17p deleted, the complex karyotypes, the patients who are Notch1 mutated, and the patients who have VH4-39 V gene family usage, which have an incredibly high risk of transformation. And when you look at the combination of Notch1 mutations and VH4-39, the risk of transformation is 100% at 5 years. So knowing those data, sitting on a patient like that is sort of hard to do.
But will ibrutinib or idelalisib prevent the occurrence of Richter syndrome? Do you have any data to indicate that early treatment with these singling inhibitors will in fact preclude the ultimate development of Richters?
We have no data to support that, but I think, at least theoretically, when the idea that a lot of these mutations are just totally generate stochastically, that anything that's going to reduce the number of malignant cells will decrease the potential by just probability of having one of those secondary events occur.
Well, thank you very much, Dr. Furman. It's been most illuminating, and we thank you for your conduct of the meeting today. I am Dr. Morton Coleman, wishing you a good day.